on alignment philosophy in TKR?
I think it's interesting in medicine and life in general.
Hello.
You have to learn, unlearn, and relearn. That's what's happening with alignment philosophy. It took me 10 years to learn that in TKR you have to get this alignment. Now I have got to unlearn and then relearn. Very tough.
A very good morning. I hope I'm audible. Can't make out much with the mic here. I think the mic isn't great. So let's talk about alignment. My job today is to try and explain very, very basic concepts of alignment, and I think 6 minutes is way too less a time to talk about it. Having said that, we know that we've all been following mechanical alignment for a very, very long time, and I would still say that mechanical alignment remains the gold standard. This is initially, we started off with two thoughts. The first thought or the first idea was anatomical alignment, and then there was another group that talked about mechanical alignment. The anatomical alignment moved to constitutional and sort of kinematic alignment, and the mechanical alignment through sort of measured resection, gap balancing, to now functional alignment. Now, before we can talk about any alignment philosophy, there are two very basic things that we need to know. The first is that no alignment talk will be complete without LDFA. So if you do not have a way to measure the lateral distal femoral angle on your patient's X-ray, there is no point in going ahead talking about any alignment philosophy. We know that LDFA is not 87 degrees in every patient. We know that the joint line tends to slope by 3 degrees, but as we do more and more robotic cases, we see there's a huge variation in the lateral distal femoral angle. The second most important thing that you need to know is the MPTA, or the medial proximal tibial angle. Again, it's not always 87 degrees. The tibial joint line does not always slope at 3 degrees. And the anatomical axis and the mechanical axis of the tibia, as we've been told, is always the same, is not always the same. There are huge variations. In fact, I would say rarely, very rarely would you find the anatomical and mechanical axis in a patient that you're doing a TKR. Now, the big question is, why are we talking about all of this? And I want you to look at this image. This image, all of this comes in from the CPAC classification, but I want you to focus for a second and look at the image with the HKA shown in red. And I want you to see now, so you've got a knee that has an LDFA, which is 87, and MPTA, which is 87. Now, you have a knee which has an LDFA of 90 and MPTA of 90, and now you've got something which has an LDFA of 93 and MPTA of 93. So if we go back with the same HKA, you have 3 different knees. The idea is that we identify which knee type we are operating, and we try and reproduce the native anatomy of that knee with regards to the LDFA, MPTA, and the joint line obliquity. If this is what we are attempting, then we are actually doing what all these alignment philosophies are conceptually based upon. The next thing that comes forward is the arithmetic HKA, which is different from the mechanical HKA that we've been talking about for a very long time. The arithmetic HKA is supposed to give us the native sort of varus that the patient had constitutionally. Obviously, it cannot be measured when there is a huge amount of bone defect, etc., but that's conceptually what we need to know. With the limited time I have, I cannot go into much detail, but essentially, if we know the LDFA, the MPTA, and we calculate the AHKA and the joint line obliquity, we know what CPAC type a patient is, and therefore we can try and reproduce that native CPAC type, keep the patient in the same alignment that the patient had prior to surgery. We do not, however, none of these calculations take into consideration the joint line convergence angle, which is a big problem in our patients. There's a huge amount of joint opening, which is the soft tissue laxity component, and therefore, while this calculation shows an AHKA of 0, the patient has 5 degrees of varus. Again, I cannot go into details because of shortage of time. So let's look at where we are. On one end, we've got mechanical alignment. On the other hand, we have kinematic alignment. I'll skip this slide again for shortage of time, and we'll just sort of go on to onto this image. So what we see here is this gentleman in the center. Now the question is, he's active, he's athletic, he's still playing. He comes to us for a knee replacement. What is it that we want to offer him? Do we want to make his knees straight? Do we want to keep his knees back to the same way as they were when he was active? And that's exactly the whole concept between mechanical and kinematic alignment. So the proponents of kinematic alignment believe that we should restore what the patient had, and the proponents of mechanical alignment want to change the alignment. Now the big question is, we all know that if we try to make this leg completely straight, it's going to involve a huge amount of soft tissue release, and this patient may not be that happy. So what is it that we're trying to reach? What we're trying to reach is neither, I think, in today's time, neither reach complete kinematic, so we restrict our boundaries to safe limits, nor are we going completely mechanical to make it completely straight. So we work within limits to sort of get, essentially, minimize our soft tissue releases, and adjust our bony cuts to within safe limits. So the kinematic philosophy moved to restricted kinematic, the mechanical alignment actually moves to sort of not exactly adjusted mechanical, but in the end, all of us are aiming at a more functional alignment, and that's our objective. So in the end, I won't go through what functional alignment is through want of time, but I think in essence, the consensus is that you adjust your bony cuts within safe margins and minimize your soft tissue release. That's what, in my opinion, the consensus statement with regards to all alignment philosophies is. Thank you very much.
Thank you, Dr. Mudit. It's going to be a very interesting session. I think we'll have a discussion at the end of the session. Please just take a seat. May I now invite Dr. Saurav Shukla to tell us about his experience with VALIS with kinematic alignment. Is Dr. Saurav Shukla here? Right. Next is Dr. Mukesh Ladda. He's going to talk about alignment philosophies and soft tissue correlation in TK.
Good morning, everyone. So Dr. Mudit Khanna kept rolling the ball, and we are here to get screwed by all these stalwarts here. So let's go. When I started, this is a new article came just recently in 2013, and a good video promoted by Ortho TV, that after spending so many hours in alignment understanding, it's still like a Devdas what to do. Nothing, no one is with you. So let me take you to some philosophies. We know mechanical alignment has worked well and has not worked well as well in many of our cases, and in most of the cases it worked well. So what bony cuts we take in mechanical? We go perpendicular to the mechanical axis of femur and tibia, and then we start releasing the soft tissues to balance the knee. There was another concept of anatomical alignment, where you put the femur in 2 or 3 degree of valgus to the mechanical axis, and tibia in 2 or 3 degree, and then the rotation on the posterior condylar axis. That's the anatomical alignment. I'm talking about bony cuts right now. Then came John Bellarmine's paper that there is something called as constitutional varus, and it is unnatural to put the knee straight in those some 32% of patients. And there comes the kinematic by Dr. Professor Howell, who says that cut the distal femur 9 mm as per the thickness of the implant, posterior and distal femur, and then keep balancing it as per your tibia cut. But that sounds scary, because more the tibia cut, we know it will lead to aseptic failure and the tibial bone loss. And they may be working well with Professor Howell in his hand, because in US and other, their patient comes very early. They don't come so late the way they come to us. So I think whenever you feel like the kinematic alignment has to be done, I think they are ideal patients for unilateral knee replace or partial knee replacement, because you have to do no releases. But Professor Howell has found a good survivorship of about 98% at the end of 10 years. Not only he, various other articles have said that the patient are most satisfied with that kinematic balance compared to mechanical alignment. That may be little controversial. So people thought then, if the cutting tibia is too scary, let's do it reverse. Keep tibia at 90 degree and keep balancing it on the femur by increasing your distal femur cut or by increasing your posterior femur cuts, and then by rotating the femur. Again, putting one bone normal and working on the other bone. Then something came restricted kinematic. You do all calculations pre-op, how much is the HK angle, how much is the MLDFA, how much is the MPTA, and play within the range so that you can get the pre-arthritic level. All this is possible with help of some instrumentation. It's very difficult to get that conventionally with the things. So all these papers which were done previously, they have done either on the patient-specific jigs, or they have some PSI, or they have done something on MRI and all that, and then they have done all this. And then came, this is the flow chart for restricted kinematics, modified kinematics where you just rotate it. Then came the functional alignment where you play both on the femur and the tibia and the soft tissue. So I feel mechanical is still people are using. Next is what functional alignment will work well, because knee is made up of femur, tibia, and soft tissue. So why only to make one thing at risk? Like in kinematic, tibia is at risk. In inverse kinematic, femur is, you are cutting more. In mechanical, we are doing a lot of soft tissue release to balance the knee. So this is what the limitations of functional alignment are. You cut the distal femur within a range of about 2 to 3 degree varus to valgus. Same for tibia, 2 to 3 degree. The whole HK axis should not go beyond 4 to 5 degree of varus. And the same way you balance with the flexion and extension gap. But for all this, you need some technology. It's extremely difficult to follow them conventionally. So this is the main topic which I want to show. In the red, how you balance in mechanical axis, knee balancing, you need frequent soft tissue releases if you do mechanical alignment. What kinematic balance is that don't do any soft tissue release, which is quite scary because it's not possible only to keep cut tibia and balance the knee. In inverse kinematic, they say don't do any soft tissue release, but in restricted and functional, you need some soft tissue release with femoral and tibial component in expected or acceptable range of, you can't put femur in 5 degree of valgus, you can't put tibia in 4-5 degree of varus. You have to be something within a range, say about a couple of degree varus on the tibia, a couple of degree varus on the femur, that automatically opens your medial gap, and that reduces your soft tissue release. I'm not saying that this alignment, I don't believe that you don't need any release if you do kinematic. I don't believe that. There are some situations where even after doing functional, you have to do release if it's a very stiff knee, not correctable under anesthesia. So you have to take it with a pinch of salt, but most of the cases with functional alignment, you may go up without releasing if you put them in a proper and measured angle. So another article which says that functional alignment achieve more balanced total knee arthroplasty than either mechanical or kinematic prior to soft tissue release, because if the tibia and femur is varus, and if you put femur in 2 degree varus and tibia in 2 degree varus, you will see it automatically opens your gap, and that reduces your soft tissue releases. So if you have, many of us see this patient, now she has a varus thrust gait, and other side she don't have that much of varus thrust gait. Now if I plan mechanical alignment on that severe varus thrust gait, I know I have to do a lot of releases to balance that knee to the lateral side, which is a lax one. So what I did one side mechanical and one side functional. This is an intra-op pic where you can see that I have not touched the posteromedial capsule at all if I am going for functional release, but if I do mechanical release, I have to do, but both of them had given me a well-balanced gap throughout the range of motion. How does it affect? So you can see this, the well-balanced full extension. There is no medial opening at all under anesthesia, even on the full extension, as well as even on the anterior-posterior if I am using the pressure. The same other knee, there is some slight 2 or 3 millimeters of medial opening in the mechanical alignment because I have to balance with a lot of soft tissue releases in those bad knees. So what I mean to say, you have an excellent balanced knee, but then less soft tissue releases occurs with functional alignment compared to mechanical. And if you balance them well, patient have very stable knee, they can even dance and all. You can't stop patient from enjoying his life, but the stability with reducing the soft tissue releases is much better than getting the stability with with extensive soft tissue release. So here, functional alignment gives you minimum releases. I'm not saying no releases, but that helps you to reduce the releases. You can do that even in this complex case where you have 25-year-old implant done, difficult to remove. You can use your CR technique. You can use this. You can put the femur and tibia in 2 or 3 degree of varus, rotation, flexion and all. And you can see the lower graph from 0 to 120. It's well balanced throughout the range. So I think functional alignment reduces soft tissue with minimum cuts. Thank you.
Lovely. Thank you very much, Dr. Ladda. Is Dr. Saurav Shukla here for his talk? Otherwise, we'll move on to the panel discussion. I guess not. So I think this whole concept has come up only in last 5 to 10 years. Let's have a quick show of hands. How many of us in the audience have access to robotics or navigation? So I would imagine what, 20%? 5%. No, there are some people here.